Hey everybody, I hope you're all doing well. Over the last few days, or the last couple days, I've received several emails, each with multiple questions relating to the material. So I just thought that this would be a good way to answer these questions instead of trying to type everything all out. Would be to just put together this video with appropriate links so you can go and you can find each question. So without any further ado, let's go ahead and go through these. So first question, I had a question concerning alveolar pressure's role in inspiration. I understand that it decreases, allowing air movement into the lungs. I'm confused to how it decreases. What causes it to decrease? Okay, so this is relating to the changes in pressure that occur during inspiration. So if you remember, the inspiration is triggered by the contraction of the diaphragm, which expands the thoracic cavity. And this expansion of the thoracic cavity exerts an expansive force on the pleural fluid. So if you remember, the pleural fluid is already negative relative to atmospheric pressure. And the difference between the pleural pressure and the alveolar pressure is the transpulmonary pressure. And that transpulmonary pressure is what determines the amount of lung volume or the extent of lung inflation that occurs. So when this expansive force is exerted onto the pleural fluid, that causes the pleural pressure to become even more negative, which causes the transpulmonary pressure, that pressure difference, to become even larger than normal. It's more positive. That increase in the transpulmonary pressure is going to cause an increase in the lung volume. So at the onset of this, the lung volume is increasing, and there is a finite volume of air or amount of air in the lungs. And so if you have an increase in lung volume, that's going to cause the air pressure in the alveolar spaces to drop. And that's what accounts for that pressure gradient that's going to cause air to move from the atmosphere into the lungs. Okay? So next question. I'm not fully understanding why the answers are correct for questions set from 2 of the practice questions. Okay, well, let's go through them. So 2-1, assuming normal compliance, which pleural pressure curve best represents ventilation with a positive capacity shift? So first of all, it should be clear that the pleural pressures are the lower curves, C, D, and E. The air pressures are the upper curves, A and B. So which of the pleural pressure curves best represents the positive capacity shift? So what happens during capacity shift is we're keeping the lungs more inflated than normal through the respiratory cycle. That doesn't mean that we're taking deeper breaths. We could have the same tidal volume. It's just that our lungs are maintaining a higher level of inflation through the respiratory cycle. So this would be E. E has, if you notice, the change in the pleural pressure, which would denote the change in the transpulmonary pressure, is the same as normal, which is the dotted or the hashed line there. But there's a greater transpulmonary pressure through the duration of inspiration. This means that the lungs are more inflated through the duration of inspiration. But the breath, the change in the tidal volume, is the same. Okay, so 2-2, which alveolar pressure curve best represents ventilation with an obstructive pulmonary disease? Assume normal tidal volume and respiratory rate. So if you have an obstructive pulmonary disease, that means there's an increase in the airway resistance. If there's an increase in the airway resistance, but you are trying to maintain a normal tidal volume, it means that you would need to exert a larger than normal air pressure to move the same amount of air. That would be B, right? A higher pressure, alveolar pressure, is going to move more air, and this is required if we have an increase in the airway resistance. Okay, 2-3, assuming normal compliance, which pleural pressure curve best represents an increase in the tidal volume? So this is where we're saying, okay, the tidal volume increases. So we're going to need to, what does that entail? That means that we need to have a greater amount of inflation of our lungs. This means that we're going to need a larger than normal change in the transpulmonary pressure. This is what happens with D. D starts out as the pleural pressure is normal at the onset of inspiration. and there is a larger net change, compared to normal, the dashed line there. So that means that we would have a increase in the tidal volume, or increase in the volume of inspiration. 2-4, which pleural pressure curve best represents ventilation for a patient with a restrictive pulmonary disease? Okay, so what this means is, and assume normal tidal volume respiratory rate. So what this means is there's a reduction in the compliance. Remember, the compliance is the relationship between the change in lung volume versus the change in the transpulmonary pressure. Another way of thinking about it is when we exert a change in the transpulmonary pressure, like say during inspiration, so the transpulmonary pressure is increasing, how much is the lungs, how much are the lungs going to inflate due to that change in the transpulmonary pressure? That's determined by the compliance. If the lungs are very compliant, some change in the transpulmonary pressure is going to produce a large change in lung volume. Conversely, if the compliance is small, that same change in the transpulmonary pressure is going to produce a small change in lung volume. So this is kind of turn that around and saying, okay, well, we're going to assume a normal tidal volume, but the compliance is reduced. What does that mean? It means that we will need a larger than normal change in the transpulmonary pressure to produce the same amount of change in the lung volume. This would be D. Okay, I'm still confused about the changes caused by breathing through pursed lips. So this was in the context of a forceful expiration for patients with an obstructive pulmonary disease. And the best way to think about it is during a forceful expiration, we're generating these high airway pressures that are down low in the respiratory spaces in an effort of pushing that air forcefully up through the respiratory airways, the conducting airways, and ultimately the upper respiratory tract out into the atmosphere. Okay, these represent resistors in series beginning from the alveolar spaces and in the respiratory airways of our lungs all the way out to the atmosphere. And what do we know about the movement of air or fluids through resistors in series? The largest pressure drop occurs across the largest resistive element. Okay, under normal conditions, the alveolar spaces or the respiratory airways have the lowest resistance. So what this means is as we're generating this forceful, exerting this force to produce this forceful expiration, we're generating this large pressure gradient between the airways of our lungs and the atmosphere. Okay, the air pressure is going to drop as the air is moving through the airways. Again, the largest drop occurs across the airways with the largest resistive element. Normally, the respiratory airways in our lungs have very low resistance. Therefore, the air pressure doesn't drop much as it's moving through those respiratory airways. When there's an obstructive pulmonary disease, those airways become much higher resistance. So what this means is the air pressure is going to have a larger than normal pressure drop as it's moving through those respiratory airways. And here's the key, is that if the pressure drops too much, and we're talking about the air pressure inside the airways, then that will reach a situation where the air pressure becomes equal to or less than the pleural pressure, which is a situation where the transpulmonary pressure becomes zero, right, or negative. And unless those airways are supported by cartilage, that causes those individual airways to collapse, right? So your respiratory airways are not supported by cartilage, so they can't withstand a zero transpulmonary pressure or negative transpulmonary pressure. Your conducting airways are supported by cartilage, so they can withstand those very low transpulmonary pressures. Okay, so if you have an obstructive pulmonary disease and you engage in a forceful expiration, it's going to cause a trapping of air or the flow limitation effect due to the collapse of those airways that aren't supported by cartilage. So how does breathing through pursed lips help? Well, it helps because when you do that, you make the upper respiratory tract, specifically your lips, super high resistance. This creates a back pressure that keeps the airways in your lungs inflated. Or another way of thinking about it is you just made your lips the highest resistive element. That's where the largest pressure drop is going to occur, is right there. And so that's going to maintain a relatively high pressure in those lower airways. Okay, so that's how it works. Hopefully that made sense. Clarification of the PCO2 and PO2 changes during hyperventilation and hypoventilation. So that's a little open-ended. I guess the big thing that the kind of the big take-home points that I'd want you to know is that we see, the effects of ventilation on the partial pressures of carbon dioxide and oxygen are different or divergent, meaning that when you increase ventilation, PO2 goes up. We're talking about the alveolar PO2, and alveolar PCO2 goes down. Well, why are they different that way? It has to do with where is the gas coming from, like what's the source of it, and then where is the gas going? Okay, so in the case of oxygen, the source of oxygen is the atmosphere, right? So oxygen's coming from the atmosphere, we're breathing it in, therefore the greater the rate of ventilation, the greater the rate that oxygen is coming into our lungs, right? Well, where is the oxygen going? The oxygen is being distributed to tissues, and it is being consumed by cellular metabolism. Okay, so that's the sink, basically, for the oxygen. Carbon dioxide is the opposite. Carbon dioxide, it's being produced by our body. It's being produced by cellular metabolism, metabolic processes within our cells. And where is it going? We're eliminating it from our body via ventilation out into the atmosphere. Okay, so that's the sink, basically, for carbon dioxide, is the ventilation of carbon dioxide out into the atmosphere. And so that's the reason why if you hyperventilate, so you increase your level of ventilation, you are simultaneously bringing in more oxygen, right, which is going to cause PO2 to go up. And you are eliminating more carbon dioxide because, again, you're producing it from your cells, you're eliminating it by ventilation, so PCO2 goes down. Okay, conversely, when you hypoventilate, that means you're decreasing the amount of alveolar ventilation. That means you're decreasing the rate at which oxygen is coming in. That's going to cause PO2 to drop. And you are then simultaneously also decreasing the rate at which you're eliminating carbon dioxide. So PCO2 is going to climb because you're not getting rid of it as quickly. So hopefully that helps. Okay, next question. The R state has a high affinity for O2 binding and a low affinity for CO2 binding and proton binding, which means it has a lot of O2 bound to it. And T state is vice versa. I don't understand why it is like that. If the R state is already saturated with O2, why would you have O2 loading in the R state if there's already a lot of oxygen on it? Okay, so that's a good question. And so here's the thing that I would point out is that the transition area or transition range where hemoglobin begins to transition from predominantly being in the T state to predominantly being in the R state, it occurs at much lower levels than complete saturation for oxygen. Okay, so the way that I would think, and the other thing to consider too, is it's not really an either or type of situation. It's the amount of time that hemoglobin spends in one state versus the other state. So the way I would think about it is that at very low oxygen partial pressures, there's 0% saturation, say, for oxygen binding to hemoglobin. Hemoglobin is going to spend most of its time in the T state, okay, which is the low binding affinity state. As the partial pressure for oxygen increases, you get more binding of oxygen to hemoglobin. And even just one oxygen molecule bound to it will be sufficient to increase the amount of time it spends in the R state, that higher affinity state. Right? You don't have to be completely saturated with oxygen for it to be spending time in the R state. Maybe it's still with one oxygen spending more time in the T state than it is in the R state. Who knows? But you should get an appreciable increase in the amount of time it spends in the R state, which is the high affinity state. And as you increase the amount of time that hemoglobin spends in the R state, that's going to favor increased loading of hemoglobin with oxygen. And in fact, I think it's fair to say that hemoglobin spends a significant amount of time in the R state, even at subsaturating levels of oxygen. Okay, so it isn't just that it only becomes in the R state when it's completely bound. That's just the way that it's often depicted, though, in figures. Okay, so it goes on. I think I understand that in the T state, it is oxygen unloading because you're in a state of increased metabolic needs. So you need more oxygen, which means you want to have lower affinity for in order to release the oxygen to the tissues. That's basically correct. So, and here's the way that I would think about it: is remember you have all this blood going to the lungs, becoming essentially saturated with oxygen, and then that blood makes its way back to the heart, and then ultimately to the systemic side of circulation. So we're on the arterial side now, or the arterial branch of the systemic circulation. So now this blood is being distributed to the tissues that are going to need this oxygen. So the effects of allosteric inhibition make it such that the oxygen will be preferentially unloaded to the tissues that need them most, to those that are actually consuming the oxygen and in the process are producing higher levels of carbon dioxide and protons. So when this blood reaches a capillary bed that is perfusing a tissue that is metabolically active, you have high levels of carbon dioxide, you have high proton concentrations. You're also producing heat as well. And those factors are going to affect the hemoglobin, destabilizing it from being in the R state, and it's going to cause it to spend more time in the T state, which is that lower binding affinity state for oxygen. This is going to favor the unloading of oxygen from that hemoglobin to that tissue. Conversely, the blood that is, say, entering capillary beds in tissues that are relatively quiescent, that have very low levels of metabolic activity, they're not producing a lot of CO2, they're not producing a lot of protons, they're not generating a lot of heat. Well, this is going to make it such that hemoglobin will spend more time in the R state, right? The R state's not going to be as destabilized because of the absence of those factors. And that means that the hemoglobin is going to be less likely to unload the oxygen there, which kind of makes sense. If I can have some clarification on this and the Bohr effect in general, I would appreciate that. So the Bohr effect, we basically just walked through it there. So the Bohr effect is just the name for that phenomena where if you have a decrease in the pH or an increase in the carbon dioxide, that decreases the oxygen carrying capacity of the blood. Why? Because those factors tend to destabilize hemoglobin from being in the R state so that it spends more time in the T state. So it exerts that allosteric inhibition that we talked about before. And that has the consequence of reducing the oxygen carrying capacity of the blood. I'm getting a little confused for static versus dynamic compliance with obstructive pulmonary disease. See, I rewatched the lectures and have written down that with an obstructive pulmonary disease under static conditions, the compliance is higher than normal and lower than normal for restrictive pulmonary disease. So that's true. So real quick, for restrictive pulmonary disease, that is the characteristic feature of a restrictive pulmonary disease is reduced static compliance. Okay, so that's true. The increase in compliance for an obstructive pulmonary disease, that's a kind of a secondary effect, typically, of some obstructive pulmonary disease. Emphysema was one example of that. And the reason why we tend to see that is because there is some degenerative loss of lung stroma and parenchyma. So basically, some of the structural features or the structural components of the lungs, essentially making the spring less springy, making it so that it's just a little bit more compliant. Okay, so that's true, but we're talking about static compliance in that case. However, I know that one of the consequences of obstructive pulmonary disease is a decrease in dynamic compliance. So you aren't under static conditions, so you don't have all the time in the world for your lungs to fill up, so that's true. But I'm confused by the fact that under static conditions, you have an increase in compliance compared to normal, but when you put a timer on it, all of a sudden it is less than normal and takes longer. Okay, so both of those things are true. So under static conditions, this is time independent. We're just talking about how stiff is the spring. And if you're suffering from emphysema and you have this loss of structural tissue within the lungs are just going to be more elastic, right? They're going to be stretchier. They're going to be more compliant. Under dynamic, but we don't ventilate under static conditions. We ventilate under dynamic conditions. And so what two features determine how long it takes to inflate your lungs? One is, well, how much air is going to move into your lungs, right? How much is the change in volume going to be? That's determined by the compliance. And then two, what's the airway resistance? The airway resistance determines the rate at which air can move into the lungs. And so I think basically, I understand the nature of the confusion here, but I think it's safe to say that the increase in resistance that occurs during obstructive pulmonary disease far outweighs, whatever gains might occur due to the changes due to the increase in the static compliance, meaning that airway resistance is going to dominate. It's just going to take longer to inflate those lungs. I wanted to start with, next question. I want to start with why, if the lungs are less compliant during inspiration, they wouldn't want to collapse. My understanding is that compliance is more inversely related to elasticity. So if the compliance decreased, wouldn't the lungs want to also decrease in volume of collapse due to an increase in elasticity as well? Okay, so let's hold off right there. So if this is, I'm not exactly sure I understand what this question is getting at. It could be, is this a question about the effects of the hysteresis, where, the lungs are actually more compliant during, the lungs are less compliant during inspiration, more compliant during expiration, at least with regards to static compliance. If so, I guess I don't fully understand the nature of this question. So the person who emailed this to me could follow up if this is not a very satisfying answer. But I don't know how the effects of the change in compliance matter, because in either case, the effects of that compliance are to the lungs tend to want to collapse. Okay, so the lungs tend to want to collapse. This is due to the intrinsic elasticity of the tissues. This is also due to the effects of surface tension. Okay, so both of these things are going to make the lungs want to collapse. During inspiration, we're working against that by causing the lungs to expand. We're pushing them in a direction they don't want to go, right? They want to go in the exact opposite direction. That takes more work. And then during expiration, we're allowing the lungs to relax back to that FRC, or to that mechanical equilibrium. So I don't know if me just talking about that helped at all. If not, please email me. Let's see. I understand too that the surface tension decreasing would help increase compliance. I think this is where I'm getting kind of mixed up and just need some help. Okay, so again, it's the effects of surface tension that's causing that inward elastic recoil. And the way to think about it is, remember we talked about the effect of like the tendencies of a bubble, right? You have a bubble, and what does a bubble want to do? A bubble wants to contract into a drop. Why does it want to contract into a drop? Because of surface tension. The surface tension is causing the water molecules to basically move inward in towards the bulk of the water solutions, even though it's a really small bulk when we're talking about a bubble, but go with it. It's moving, the water is moving away from the air-water interface, and that's causing the volume to contract, and really all it wants to do is it wants to be a bubble, or it wants to be a drop. So we have this bubble that wants to be a drop. And so the effects of surfactant is to decrease that surface tension, to decrease that tendency for those bubbles to contract. So why is this a relevant analogy? It's relevant because all the individual alveoli in our lungs, in our airways, they all approximate little bubbles, because they all have the layer of fluid on the inner lining of each individual alveolus, which is causing each individual alveolus to want to contract. And so the effects of the surfactant is to decrease that tendency. So, okay, hopefully that was helpful. I think the second part that is confusing me a little is how exactly pressure works in this. Is transpulmonary pressure in these examples working independently of volume at first, causing a change in the compliance? Okay, so transpulmonary pressure doesn't change the compliance. So the relationship is this. The transpulmonary pressure is the pressure difference between the air in the airways, or inside of our lungs, and the fluid outside, okay? And so the effects of compliance is, well, given whatever that pressure gradient is, that pressure difference is, this is how inflated our lungs are going to be. So when we increase our lung volume, we do this by changing the transpulmonary pressure, making it larger, okay? That will cause the lung volume to increase. How much does the lung volume increase? It depends upon the compliance of the lungs. If the compliance is really high, then the lung volume will change a lot. If the compliance is relatively low, then the lung volume will not change as much. why is it that the pleural pressure needs to maintain a negative pressure during normal quiet breathing? I'm not sure what you mean by quiet breathing. Is this just normal breathing when an animal is not physically exerting itself? Exactly. So that's what quiet breathing is. It's at low or minimal ventilatory effort. It's what you just do normally when you're just kind of sitting around. This engages the diaphragm is the primary muscle that accomplishes this form of ventilation. It is when you're ventilating with higher effort that you have appreciable recruitment of auxiliary ventilatory muscles. And then why is it the pleural pressure needs to maintain a negative pressure during normal quiet breathing? Because the pleural pressure is part of that transpulmonary pressure, which again, you have to have a positive transpulmonary pressure or positive pressure difference between the inside of the airways and the outside of the airways for the airways to be inflated. Right? It's like, the air, when you're blowing up a balloon, you're able to accomplish this by making the air inside the balloon higher in pressure than the air outside of the balloon, right? So it's just the other way. It's like the other side of basically of the same coin, thinking about the changes in the outer pressure, that pleural pressure, compared to the pressure in the air inside the airways. So basically, in order to have an inflated balloon, the pressure outside has to be less than the pressure inside. This is true whether we're talking about a balloon, also true if we're talking about the airways, and having a more negative pleural pressure than the air pressure itself. Beebe will explain why expiration is a passive process. Is it passive simply because there's no muscle contraction, just diaphragm relaxation? Yes. So you relax the diaphragm, and then remember, because of that inward elastic recoil, the lungs are going to go back and they're going to assume the volume at functional residual capacity. They're going to reassume that state of the mechanical equilibrium that occurs between that inward elastic recoil of the lungs and the outward elastic recoil of your thoracic wall. Also, I'm having a hard time understanding pulmonary surfactant and surface tension. I know that pulmonary surfactant increases lung compliance. So I just talked about that a moment ago. Surfactant decreases the surface tension. It does that by, without getting into all the details, remember, essentially the water molecules don't want to exist at the air-water interface. They're being pulled down into the bulk of the solution by the intermolecular interactions with the other water molecules that are there, the population of water molecules in the solution. And by contrast, the surfactant, due to the hydrophobic elements, is happy to sit at the air-water interface. So it occupies the air-water interface. That means less water molecules are being pulled down into the solution. That decreases that tendency for our alveolar bubbles to want to contract. Right, because it's that inward movement of the water molecules from the air-water interface that's causing that contraction. If you have a bunch of surfactant there that's not being pulled inward, the bubbles are happier, basically being as a bubble and not a drop. Are the effects of increased dead space best overcome by increasing respiratory rate or tidal volume? I'm not sure if I understand the question correctly, but is this getting at how both hyperventilation and hypoventilation are ultimately not good? Well, no, I mean, they're related concepts. So this is, but I think kind of two separate issues. So first of all, are the effects of increased dead space best overcome by increasing respiratory rate or tidal volume? So I think so first of all, dead space, the effects of dead space are to produce what we call dead space ventilation. So remember, the minute ventilation is the total amount of air that is exchanging back and forth between the atmosphere and our lungs. Okay, and why are we doing this in the first place? We're doing this because we want to get that air down into the respiratory elements where gas exchange can take place, where we can, unload the O2 can load into the pulmonary capillaries and the CO2 can unload into the alveolar spaces and we can get rid of it. Right? That's the point of it all. But not all the air that we are moving, that we're like say inhaling during inspiration, makes it all the way to the respiratory areas. Some of that air gets left in the dead space within our lungs. And so what determines how much of that air that we ventilate, say, per minute is ventilating just the dead space versus how much is actually making it into the respiratory areas or alveolar ventilation. That's determined by, well, what's the volume of dead space in our lungs, or anything else that we might be ventilating through, like in the case of equipment dead space, like a snorkel, and what's our respiratory rate. So our dead space ventilation is the product of those two things: dead space volume, respiratory rate. And so this means then, if you have increased, like say you start breathing through a snorkel, okay, so all of a sudden, assuming you're ventilating normally, you go ahead and you put a snorkel in your mouth. You just added dead space, in that form of mechanical dead space. If you don't change your ventilation pattern, you're going to asphyxiate, right? You're not, now all of a sudden, you're not getting as much oxygen. Your alveolar ventilation is reduced because more of your minute ventilation has become dead space ventilation. So you have to increase your rate of, either your respiratory rate or your tidal volume to bring your alveolar ventilation back to normal. So which would you choose? Increase respiratory rate or increase tidal volume? That's kind of basically the crux of this question. Increase tidal volume. Why is that? Because if you increase your respiratory rate, just keep your tidal volume the same, but just start taking more breaths, yeah, you can increase your alveolar ventilation, but you are also simultaneously increasing your dead space ventilation as well, because remember, it's a product of the respiratory rate and the dead space volume. So it would take a much higher minute ventilation or total minute ventilation to bring your alveolar ventilation back to normal than if you were to just simply increase your tidal volume. If you increase your tidal volume, the dead space ventilation is unchanged. And so any increase in your total minute ventilation by increasing your tidal volume just increases your alveolar ventilation. So it's much more efficient. Okay. The second part of the question, hyperventilation versus hypoventilation, both are ultimately not good. Again, the point of that, though, is different. What do we mean by hyperventilation or hypoventilation? What is this actually even referring to? It's referring to whether our alveolar ventilation is appropriate for our blood gas demands. How do you determine that? It's determined by what's your partial pressure of carbon dioxide. Okay, that's the kind of the gold standard method for determining whether you have an appropriate alveolar ventilation. It's your PCO2, and you expect it to be somewhere around 40. Okay, if your PCO2 deviates from that significantly, say it's higher than 40, say 50, 60, whatever millimeters of mercury, that would indicate hypoventilation. You're not ventilating enough to get rid of the CO2 at the rate at which you're producing it. Conversely, if your PCO2 drops, say 30 millimeters of mercury or lower, that's hyperventilation. Now you're ventilating too much. Your alveolar ventilation is too much. Well, that's all the questions I have for right now. So hopefully this was helpful. As long as this was useful to everybody, if I get a bunch more questions, I'll do a similar format. I'll also have additional Zoom sessions if you want to ask some questions in real time. So, all right, well, hang in there. Hopefully see you all in Pullman sometime soon.